I believe we're at a critical juncture for oncology research and clinical care. Throughout my 25-year career in clinical oncology and translational cancer research, we frequently encountered different financial pressures, such as fluctuations in the federal budgets for research through the NIH and the NCI, as well as Medicare and physician reimbursement cuts through the federal funding of oncology delivery. These challenges have historically posed risks to the remarkable progress made in the U.S. for advancing fundamental discoveries and moving them into the clinic, such as cancer biology leading to targeted therapies in genome-guided oncology treatment, immunology and cellular therapies translating into CAR T cells, adoptive cell therapies, radiopharmaceuticals, bispecifics, etc. This progress has been pivotal in developing these new treatments that extend and improve the lives of countless cancer patients globally. The U.S. oncology care delivery system in particular has evolved into one of the highest quality systems worldwide, the envy of many other countries where patients travel to the U.S. To receive oncology care at the highest level. But I can't really recall a period of such immense clinical productivity and research advances when the simultaneous threats to the foundation and the progress that we've observed has really emerged in such a short period of time, such as the last few months. Concerns are converging regarding Medicare, Medicaid, and hospital-based reimbursement cuts, and these mechanisms are now at risk. When identifying and addressing fraud and abuse, we believe that this is essential and important since we're dealing with taxpayer and insurance-funded premiums that are essential for economical application for the best financial use and care of the cancer patient. But implementation of these changes rapidly without an understanding of the consequences is likely to have unintended detrimental effects on consistency in clinical management, leading to haphazard emergency services for cancer patients, and overall leading to increased overall costs rather than cost savings. As a physician scientist myself, witnessing potential risks to the future talent pipeline in academic oncology is also deeply concerning. It takes at least a decade to create a fully trained and competent oncologist in the various disciplines. The dramatic and sudden alterations in the NCI Cancer Centers program, its peer review process for NCI designation, and our training programs effectively changing rules in the middle of the game for a number of individuals who have tried to devote their careers is a major concern and has triggered widespread alarm. It raises a critical question. Does Congress truly grasp the magnitude of what is at stake based on administration budgets, changes in funding mechanisms that have converged in parallel over such a short 3 to 4 month time for a system that took 50 years to develop and evolve and build its different revenue streams and productivity? Encouragingly, some leaders within the Senate and the House of Representatives do recognize the immense value of a productive workforce, coupled with exceptional cancer prevention and timely care, and that these hold great opportunities for population health and economic competitiveness of our nation. And although a few $1 billion certainly represents a substantial sum within the context of an overall multi-trillion-dollar federal budget, it's a relatively minor adjustment that nonetheless imperils the future of cancer research. When former NCI Director Dr. Ned Sharpless tried to increase the funding payline for R01 grants to the 15th percentile, but budgetary constraints limited it to the 10th percentile, we were disappointed but understood and adapted. Now the current proposed NCI budget cuts, along with a 5-year upfront payment of a grant, suggest that the fundable threshold may go down to the 4th percentile, turning away 96% of the submitted grants, many of which are very high quality and urgently needed to advance discovery, translation, clinical trials, and often lead to revenue generation through biotech and pharmaceutical commercialization. In the clinical realm, proposed reimbursement changes affecting the 340B drug discount program, which is a cornerstone subsidizing and supporting high-quality care for eligible disproportionate share hospitals when direct professional billing is insufficient, is equally troubling. So many of us in cancer research and oncology treatment chose these careers despite the opportunities for higher salaries, lower tuition costs, and more immediate permanent employment. In order to continue to attract the brightest minds to the field, the question remains whether the administration and Congress can get together and recognize the favorable cost-benefit model of investing in biomedical research and the oncology enterprise. We certainly hope for this realization and continue to work with them to pursue alternative revenue streams, such as commercialization opportunities, as well as philanthropic supporters and foundations. But we certainly rest on the ongoing deliberations in Congress, particularly the Appropriations Committee leaders of both the Senate and the House. We hope they perceive the profound value of this tremendous enterprise, built over 50 years of national investment, which should not be disregarded or deconstructed in a half a year or so. Our system has fostered some of the most effective efforts in cancer prevention, delivered successful cancer treatments, and established robust educational pipelines to replenish the ranks of oncologists and researchers with tremendous benefit for this country and all of humanity. We're at a vulnerable time, and I'm optimistic that there is still an opportunity to rectify this and stabilize this very troublesome and vulnerable time.